thank everybody who has come so early in the morning at 8 o'clock. I think as time passes, we will warm up and we'll have more people. And welcome to this course IC551, which is on Masterclass in Diabetic Retinopathy, Basics and Beyond, a step-by-step approach, and what is our role to AI. And I have galaxy of speakers who would be joining us very soon. Dr. Lalit Verma, Dinesh Talwar, Rajiv Daman, Vishal, Manisha, Dr. Ritu, Dr. Bhuvan, and we have a keynote address by Dr. Sampath, who will be talking on the BISMA experience in DME solutions, double whammy. He is in UK catering. Welcome, Dr. Sampath. So my talk initially is on introduction, epidemiology, pathophysiology, imaging, and algorithmic management planning. Too many things to cover in 10 minutes, so I'll be brief about each one of them. We know that these three countries, China, India, and US, almost make up half of all the diabetics all over the world. And if you look at the number of diabetics as they're increasing, in 2021, 1 in 10 were diabetics. In 2030, at about 1 in 9. And in 2045, 1 in 8 living on Earth will be diabetics between the age of 20 to 79, which is a huge number. Prevalence of diabetic macular diabetes mellitus and diabetic retinopathy worldwide. We have seen that over the years, the incidence of VTDR has increased. In 2020, it was 28.54 million worldwide, and CSME was 18.83 million. By 2045, this will jump up to about 44.82 million VTDR and 28.61 CSME in 2045. So it's very rapidly increasing. These are the estimates in India, and a lot of credit goes to Rajiv for having done numerous studies. I wish I had time. That would probably take about an hour to talk all about various things he has published. But we have roughly over 100 million people, and the figure was that by 2045 we'll reach about 130 million, but I think we'll reach that much earlier. The prevalence of diabetes mellitus is increasing, and the rural areas catching up rapidly because of the rapid urbanization, and the difference between the urban and rural status of diabetes is reducing. These are the various maps of the prevalence of diabetes in the country, and the conversion rate of dysglycemia was 45.1%. For pre-diabetes, it's become almost as high as 58.9%. Now, I will not cover each of these factors, but I think they will be covered over the period of the entire course. And these are important: obesity, albuminuria, serum lipids, how they contribute, abnormal sleep patterns, hemoglobin A1C, the role of dietary fibers, anemia, the cardiovascular score, and neuropathy is important. Because my thing is on the introduction, so let me just brush over all the various matters, and then individually everybody will take over. So pathogenesis, we know that the five essential pathologies which are processes which are involved: formation of microaneurysms, increased vascular permeability, vascular occlusions, and there are proliferation of new blood vessels, then contracture of the scar tissue and causing retinal detachment. This is a very nice video. I thought I'll share it with you, which can I have the sound?
This imbalance causes fluid to accumulate in the retina, resulting in
Can I have
intracellular
sound,
and
please?
extracellular.
Yes. Huh? Are they? Okay.
Edema. Hyperglycemia causes oxidative stress that initiates activation of the retinal glial cells to produce a number of inflammatory cytokines, including interleukin-1 beta, interleukin-6, TNF, and also VEGF. The upsurge of these cytokines attracts more cells migrating into the retina. Activated microglial cells proliferate and migrate into the subretinal space. As a result of abnormal transcellular channel formation in the diabetic retina, transcytosis of mediated microglial cells is impaired and leads to accumulation of cells. The trapped microglial cells continue to produce inflammatory mediators that further amplify the inflammatory response and ultimately leads to disruption of the inner nuclear layer and neuronal cell death. Concurrently, the upsurge in inflammatory mediators and oxidative stress leads to dysfunction of the homeostatic control mediated by Muller cells. Cur4.1 channels in the Muller cells are downregulated, leading to reduction of transportation of potassium ions from the Muller cells. Continued uptake of potassium by Cur2.1 channels and osmotically coupled water molecules causes the cells to balloon, leading to intracellular edema and a loss of function of the cells. The intracellular swelling, edematous cyst formation, accumulation of extracellular fluid, and damage to microvessels may result in neuronal degeneration and photoreceptor loss. In addition, altered tight junctions of the RPE cells that can occur in the diabetic retina may cause subretinal fluid to accumulate as a consequence of Starling's law. Microglial cells secrete cytokines, chemokines, and neurotoxins in response to endogenous triggers in the degenerating retina. These increase capillary permeability and further amplify the inflammatory response. Continual dysfunction of the blood-retinal barrier allows leakage of fluid, proteins, and other macromolecules to leak into the retinal extracellular space, resulting in extracellular edema and macular thickening.
So I thought that was a very nice way of summing up the pathogenesis. And we know that the main culprit is hyperglycemia, and there are numerous other pathways which are involved. And these pathways are then targeted by anti-VEGFs, steroids, lasers, and there are other molecules which are being considered. So why should we try to recognize DME? It's because it's a leading cause of visual loss in diabetic patients, especially type 2 diabetics. In ATDR3, a risk of moderate visual loss in untreated DME was 32%. The reason why we should be doing it is because treatment is available and early identification, early treatment will prevent visual loss. Over the years, we have understood that a better way to define diabetic macular edema is a center involving and a non-center involving diabetic macular edema, and people should please understand that it is a central subfield of 500 microns, which is important for anti-VEGF treatment, though ETDR has told us that in recurrent cases you could go as close as 300 microns, but most of us do not go closer than 750 microns, and this must be kept in mind. Over the years, things have evolved, and we have gone from a normal standard photography. We learned about the 7-field photography systems. We were treating these patients earlier with focal lasers, but we don't treat this anymore now because anti-VEGFs are available. We were treating these cases by doing a scatter laser photocoagulation, but we have better options of identification available, and we know now that about 10% of the time peripheral lesions suggested a more severe assessment of ETDRS, which I'll show you. This patient who had recurrent vitreous hemorrhage, we were able to identify the areas of capillary non-perfusion and NVE, and they were treated. If I did not have an ultra-wide field fundus imaging system, this is what I would have seen. And this patient was followed up multiple times. He had multiple recurrent vitreous hemorrhages. When he resolved, we were able to treat the capillary non-perfusion areas, treat the NVEs, and the patient responded well. He is doing well now, and he's maintaining a hemorrhage-free span for almost now 1.5 years. This is his right eye, which was treated in a similar manner, and he is doing well. We also have now ability to do, and this has been there for quite some time, because the SLO method of imaging, that oral fluorescein angiography, can be done. And it is important to classify your patients when you do OCT, and this I think Vishal will be covering in much greater detail. Depending on the type of OCT pattern, you decide what treatment you're going to give. Please remember that metabolic control of diabetes is important at all stages, whether it is the non-proliferative or the proliferative diabetic retinopathy, which is clearly exemplified in this patient. This is many, many years back who refused all treatment, which is not correct, but he went ahead and did a lot of yoga, meditation. 6 months later, a lot of his lesions had disappeared, and which is quite remarkable. This patient who came to me in a multi-speciality hospital was first detected with a diabetic macular edema, was treated for about 8 months, underwent dialysis, and you can see the remarkable effect. Anemia is important, and this is maximally exemplified by a patient with thalassemia major who had thalassemia minor, who had received multiple injections of anti-VEGF, and this was in 2008. At that time, patient had received Lucentis, was not improving. When we went and treated her with vitrectomy, and this was a non-tractional edema. So many times you get cases who have persistent diabetic macular edema, but if you do an angiogram for them, you find large areas of capillary non-perfusion, you find NVE, and if they are lasered, you are able to treat the macular edema well. It's important not only to detect the macular edema, but also to detect an associated pathology like a vitreomacular traction or an epiretinal membrane, and treat the coexisting pathology, because that is extremely important. Like this patient, both in the right eye and the left eye, was treated and eventually was treated with diabetic vitrectomy, and is important. Ureta has exemplified the algorithmic approach to managing these patients of diabetic macular edema. So patients with history of cardiovascular event or pregnant women in the initial part should receive corticosteroids, and the pattern is clearly exemplified. This is the algorithm which I think is available in our handouts, which you can access. This particular table, which is also there in the handouts, you can access, because this is a very important table which identify biomarkers which correlate to the response of different treatment methods. Lately, autofluorescence is picking up with the end glycation products, and I think we will be able to understand what is metabolically happening in the retina, and with these multiple imaging techniques, we are able to assess it better and treat it better. This is something which is dear to me, is a micropulse laser, which we have been doing for quite some time, and we know that micropulse laser is effective in cases of diabetic macular edema. Like in this particular case, we treated with the micropulse laser and the patient responded well. I have also now have a small series of cases where I have done a micropulse pan-retinal photocoagulation with a continuous wave laser, and this case exemplifies that particular concept. Where Octa was followed up for last 5 years. This patient is on a follow-up with me for last 10 years, and this is the picture, and this is how the patient's retina on a wide field angiography looks like. Those are the areas where micropulse was done, and those are the areas which you are seeing are continuous wave laser. We followed it up with field charting for this patient, both 120-2 and 24-2 testing, and we found that the fields, we could save the fields. How long that will be possible? We have taken a special consent in all these patients that we are varying from the protocol of doing pan-retinal photocoagulation, but they agree and they are happy by maintaining the field. So thank you very much. Now let me invite Dr. Dinesh. He'll be talking on the role of anti-VEGFs. Dinesh, all yours, and I think we can have an interactive session at the end of the session. Thank
you. No audio. Thank you, Ajay, for inviting me to be a part of this course. And now we come to, after the basic epidemiology, we come to the management with anti-VEGF agents. This is my disclaimer and financial disclosure. Now, diabetic retinopathy is not one condition. It is a continuum from preclinical retinopathy all the way to advanced end-stage diabetic eye disease. And the treatment points for diabetic retinopathy actually start at the stage of no retinopathy, which is with medical treatment. And then as the disease progresses, the next stage of treatment jumps in, but the previous one doesn't stop. So you don't stop medical treatment because you're going on to the ocular treatment, and then you need ocular treatment for both for maculopathy, PDR, and the sequelae of PDR. Now, before we go further, as far as diabetic maculopathy is concerned, I want one concept to be understood, and that is that when we talk of center involving macular edema nowadays, we are forgetting that the center involving macular edema may have its leaks somewhere more than 500 micron from the foveal center, which means it is then amenable to laser. By missing this critical point, we actually end up skewing our treatment towards more and more injections and forgetting the role of laser altogether. So even if you're talking of anti-VEGFs, don't forget this. Now, both the RESTORE and the DRCR-NET protocol I showed us that anti-VEGF treatments work, and they actually gave a misconception that anti-VEGFs alone are better than a combination of anti-VEGFs with laser, suggesting that laser treatment is actually deleterious for the treatment. But just to show you this subgroup analysis of the same study, you see that if you've done a focal macular laser, there is no difference between laser plus anti-VEGF versus only anti-VEGF. On the other hand, if you're going to do a grid laser in diffuse diabetic macular edema, the vision drops and the outcomes fall down. So the fall that you see in the previous slide is actually attributable to treatment done for grid by grid rather than by doing a focal macular laser. Focal macular laser gives you both the benefits, decrease in number of injections, as well as maintaining the vision. So don't forget that. Now, which anti-VEGF to use when? The protocol T gave us a lot of information on this. It compared aflibercept with ranibizumab and bevacizumab, showed that aflibercept was definitely better, though the difference between the first year and second year came down. However, what is more striking was that in patients who have poorer vision, the poorer the vision, the better the effect of aflibercept. So it stood out as compared to the other drugs when the vision dropped. In patients with good vision, all the three drugs seem to have the same visual outcome. But before you say that all of them were identical, make a note of this. Diabetic macular edema, your objective is to reduce the edema, and with bevacizumab, that reduction is almost half of what you get with ranibizumab and aflibercept. So even in your good vision patients, you don't start with bevacizumab, you start with ranibizumab or aflibercept. In patients who have poorer vision than 6/12 at baseline, there is no question that the best drug is aflibercept. Even more important is the fact that if you see the effect of 3 consecutive injections with aflibercept, around half of your patients will get better than 2-line improvement. Now, those who get this improvement are actually elite responders, and they will not need a switch to any other alternative drug. So you know by 3 injections whether this patient is going to stay well on this treatment or not. On the other hand, there are going to be another 25% of patients who've got less than 5-letter improvement. Now, these are the patients who need to switch. Rather than waiting 6 injections, 7 injections, continuing indefinitely, this is the way probably to go. Now, if you were starting with ranibizumab, the elite responders number something like 25%. So that's the difference. So the 25% who respond to ranibizumab, you definitely don't need to do anything else, because these patients with 3-4 injections will become all right for the whole year. Now, the other important thing is that when the central subfield thickness is very high, more than 400 micron, aflibercept is probably the best drug to use. In patients who have the edema less severe than that, less than 400 micron, both ranibizumab and aflibercept are similar. But you'll have patients who can't afford all these drugs. Now, the patients who can't afford these drugs, laser treatment, when given in conjunction with ranibizumab and bevacizumab, gives you the same degree of drying as aflibercept as monotherapy. So the patients who can't afford monotherapy with aflibercept can be tackled by a combination of these two drugs. The other important thing is you get these patients who got better than 612 vision, 6/9, better than and N6. Now you say, do we need to treat them? Well, all this time I've been saying for many years, these patients don't need treatment. Just follow them up, and if they deteriorate, you can treat them. The protocol V actually says the same. You could not get better results by treating these patients even with aflibercept. You got the same results as those who were managed conservatively. So the best approach is continuous monitoring till you see early signs of deterioration, and then you can initiate the anti-VEGF treatment. On the other hand, if you get patients who have a decrease in either distant vision or near vision, now you see the point to be added here is near vision. We forget, all the studies talk about distant vision. The fact is, if your near vision has got down to N10, the patient still needs treatment. So both decrease in near vision and distant vision are indications for treatment with anti-VEGF agents. The treatment is PRN from initiation. This is not a loading dose. It could be that the patient needs 3 injections, he needs 5 injections, he may need only 1 injection. But it is not a loading dose of 1, 2, 3, 4, 5. It is a PRN from initiation. Continue to give monthly till the patient reaches a normalization of the foveal contour with normal vision. And then you can stop treatment and follow up. But if this endpoint is not reached, then you need to continue the treatment. And I would say that if you have 2 consecutive injections after your first 2-3 injections, and there is no change, then this patient needs to be tried on steroids. As far as proliferative diabetic retinopathy is concerned, you have a combination of lasers, anti-VEGF agents, and steroids available. The protocol S said, hey, anti-VEGF agents are great, better visual outcomes, less loss, better fields, but PRPs are not without advantages. Fewer visits, fewer injections, more cost effective. But even more important, in patients with diabetic macular edema, and people never talk about this, those who had only monotherapy needed more injections, whereas those who had combination with PRP had half the number of injections, thereby in a very big study telling us that doing a PRP decreases the macular edema too. It is not just effective for treating the PDR. The more important thing is that when you treat with monotherapy with anti-VEGFs and the patient doesn't come for follow-up, you end up with vitreous hemorrhage, neovascular glaucoma, and tractional retinal detachments in a substantial number of patients. And in fact, in one of the studies, 50% of the patients ended up with vision of hand movements or worse, because he's under the feeling that nothing needs to be done. Now, so what is the way to go for these patients? Probably the best way is a combination of anti-VEGFs with PRP. And there was a study called the Proteus study, which actually showed that yes, this combination is better than only PRP. You get better regression of total regression of neovascularization with the combination rather than in PRP alone. The Pride study compared monotherapy also and found that the best results were with monotherapy. Within 3 months, everything regressed, but it came back. By the end of the year, 17% of patients had recurrences. Combined therapy, long term, nothing was left over. So recurrences are more following monotherapy. Laser may be better for high-risk PDRs, and combined therapy gives the most sustained results. So today, I would follow up for treat these patients, raise neovascularization, complete the laser first, anti-VEGFs later, flat neovascularization, laser prior to or soon after an anti-VEGF treatment. And if you still have NVE persistent after adequate laser, this is the best group for anti-VEGF treatment now. And we'll come to the role of monotherapy. I believe monotherapy with anti-VEGFs is like catching a tiger by the tail. You've caught it, now you can't get off it. So the best way is not monotherapy unless you explain to the patient that this patient now may require 14 or more injections in 2 years with the possibility of more later. It doesn't finish there. You still need regular follow-ups. If you don't follow up, you'll end up with the secondary glaucomas and TRDs, which I talked about. And so, if your patient says, "I want monotherapy," I will come month after month. Follow me up with that. Go ahead. Ladies and gentlemen, judicious use of anti-VEGF agents as part of a multi-pronged attack can definitely help to preserve and improve visual function in patients with diabetic retinopathy, possibly even indefinitely. Thank you very much, ladies and gentlemen.
Thanks, Dinesh. That was wonderful. I think we'll save the questions for the end so that all speakers can give their talks. I will call upon Dr. Vishal to talk on diabetic macular edema clinical presentation, particularly role of steroids, lasers, and surgery. Vishal is prolific surgeon, retina practitioner at Jaipur.
Thank you, Ajay sir, and thank you for making me a part of your wonderful course year after year. And I'll be speaking about the role of steroids. I'll be talking about the role of steroids and surgery in DME. Lasers will be covered by my subsequent speaker, Dr. Bhuvan. So, just a brief, we all know that the diabetic macular edema is a chronic and a multifactorial condition. It's one of the most common diagnoses we make in our retinal OPDs, and it causes a visual impairment that critically impacts a patient's quality of life. And traditionally and still, anti-VEGF agents are the gold standard for the first line treatment in the management of DME. But now we know that only around 1/3 of DME patients show more than 3 lines of visual improvement with anti-VEGF, suggesting the role of basically inflammation in the pathogenesis of DME. And so many molecules are involved, and it has been proved, like addition molecules, ICAM, VCAM, integrins, IL-6, IL-8, and the role of Ang2 has been well established in the pathogenesis of DME. So besides VEGF, there are various pro-inflammatory agents responsible for diabetic macular edema. And even if you see the data for anti-VEGFs amongst eyes that showed limited initial visual acuity improvement with anti-VEGF monotherapy only 1/3 of them showed a clinically significant long-term visual response, and at the end of the 2 years, the response was very less, and at the end of 3 years, it was less than at the end of 2 years. So the current perspectives on the role of inflammation in diabetic macular says that DME patients have elevated concentrations of these pro-inflammatory cytokines, IL-6, IL-8, MCP1, and of course VEGF. And for the concentration of the remaining cytokines, there was no difference between patients with DME and healthy subjects. So what about dexamethasone? Is it effective in inhibiting inflammatory cytokines in DME? Well, the evidence says so. So you can see the percentage of patients with a 3-line improvement from BCVA from baseline at the year 3 or final study visit. It shows a significant improvement in visual acuity. Even Dex implant 0.35 mg shows statistical superiority to sham patients. And eyes with anti-VEGF treatment in the first year, and they were switched later in the second year to steroids, also showed functional and anatomical improvements. And of course, those who switched early to dexamethasone in the first year, of course, had better visual gain. So eyes that switched early to dex implant had, of course, a better outcome because at 12 months and could maintain it across the second year. And those who switched did not have that much improvement, but still they were better off than the previous anti-VEGF treatment, of course, because of irreversible photoreceptor loss. So why are we in our clinical practice hesitant to give steroids early in diabetic macular edema? Of course, the most common answer would be that we are, still averse with adverse effects like cataractogenesis, maybe IOP rise, and we all know that that can be easily managed by medical management, and cataractogenesis is not a very major problem. And the main concern is that we ourselves do not know that how many, what subset of patients have suboptimal treatment outcomes with anti-VEGF. We keep on injecting anti-VEGF, and many of these patients we do not follow up regularly to see the magnitude of suboptimal treatment load. So the guidelines say that it is the DEX implant is a preferred uh, uh, you know, steroid therapy among all the available corticosteroids. It can be used as a first line in pseudophakic eyes. It can be used as a first line in patients with cardiovascular events, and those patients who are unwilling to attend monthly or regular anti-VEGF treatments. So the indications are steroid use is history of major CV events, pseudophakic eyes is the first line treatment, and in phakic eyes, of course, anti-VEGF is the first line treatment, but can be given to patients not willing for regular checkups. And the expert recommendations using Delphi-based approach recommends that apart from the previous recommendations, you can consider, DEX implants in patients who are not responders or suboptimal responders after the loading phase of anti-VEGFs. And among steroid treatment, dexamethasone intravitreal implants were considered to have the best ocular tolerability. So just to summarize, the naive eyes, treatment naive eyes, suitable patients are pseudophakic patients and not suitable for anti-VEGF agents or poor treatment adherence. So it gives good anatomical response, faster resolution, and does not cause systemic adverse effects. And in switch eye, non-responders, that after the loading dose of anti-VEGF, if there is only a less than 10% reduction of central subfield thickness or less than 5 liters of BCVA. And in inflammatory scenarios, on the OCT, if the diabetic macular edema shows the telltale signs of inflammation, that is the NSD neuroepithelium detachment or hyperreflective foci. So the key takeaways about the role of steroids in the management of DME is that, of course, we know that still the first line of treatment for DME is anti-VEGF agents, but many patients fail to show a visual response after a prolonged anti-VEGF treatment protocol. Inflammation is the main culprit in these non-responders, and intravitreal corticosteroids are useful in the management of DME as they block the production of VEGF and pro-inflammatory cytokines. So they show efficacy in the treatment of DME along with the favorable safety profile. So coming to the surgical aspect of the treatment of diabetic macular edema. So let's divide it into 3 parts. First is, of course, it's a recognized definite indication, that is a taut posterior hyaloid membrane, vitreomacular traction, and epiretinal membrane, which is causing actually a physical macular edema. A relative indication is a non-responder patient, that is a patient with recalcitrant macular edema after a prolonged therapy of anti-VEGFs, maybe steroids, and still has persistent macular edema. And now studies have come up with treating ILM with vitrectomy and ILM peeling in treatment naive diabetic macular edema. I do not do that, and I think that comes in the category of overzealous treatment, but it remains to be seen what are the results. But all these indications yield excellent anatomical results with reduction in central subfield thickness. And the rationale is that vitrectomy, by doing a vitrectomy, there is improvement of vitreous oxygenation. There is a reduction of the cytokine levels and vitreous VEGF levels. And ILM peeling per se is beneficial for the resolution of DME and visual acuity improvement. So just a couple of videos to tell you how it is done. It's a straightforward surgery. This is a patient of a taut posterior hyaloid membrane, and a PVD induction is there. You have to stain multiple times to reach the ILM because every layer has to be peeled separately. You can see this glial white tissue, and that is your taut posterior hyaloid membrane, and it comes easily with the forceps. You don't need you don't need even to stain it, and it's actually very it comes in one piece. And after that is removed, you again stain it with the brilliant blue dye so that the ILM now takes up a good stain. And this is the final peeling. So we have removed the vitreous, did a PVD induction, removed the taut posterior hyaloid membrane, and the final step is to peel the ILM. Of course, the traction was resolved and the patient had some improvement, but you can see that a subfoveal plaque over there, which did not, nothing could have been done for that. So this is the pre and the post OCTs. Another case of taut posterior hyaloid membrane. Here, the visualization was poor, so we injected trypan blue to stain the taut posterior hyaloid membrane. So it was, just forward it. So you catch hold of that with the end gripping forceps. Just the last video. and again it, comes up as a sheet. In this case, it was bluish in hue because of the trypan blue staining. And the final step is the common ILM peeling after the third staining by BBG. And this is a peeling in a non-tractional edema for a recalcitrant macular edema without any TPHM or without any VMT. And you just do a simple ILM peeling in these cases, and the results are very good. Although many of these cases do not, the visual acuity improvement does not resonate with the anatomical reduction in central subfield thickness. So to conclude, vitrectomy for DME, the indications and extent keeps on evolving with time. No diabetic vitrectomy, mind you, especially for the youngsters, is a straightforward procedure, and you might end up in complications with poorer visual acuity than pre-op visual acuity. But of course, it remains an important tool in the management of select cases of DME. And the concept that thinner macula doesn't correlate with improved visual acuity should be made adequately clear during the pre-op counseling to the patient. Thank you so much, and I invite you to the National Indian Retinopathy of Prematurity Society conference to be held in Jaipur in July this year. Thank you so much.
Thanks, Vishal. That was wonderful. Bhuvan, can you come for your presentation next? Bhuvan will be talking on current role of lasers in diabetic retinopathy in the anti-VEGF era and the newer lasers. We welcome Dr. Mangat Dokra. We thank you for coming for the course, sir. Welcome.
So very good morning to all of you, and I'd like to thank Dr. Ajay for including me in this course, and we have been conducting this for the past 3-4 years now. So I think all the interesting part of anti-VEGF and surgery has been done. So I'll be focusing on the boring part, that is lasers in diabetic retinopathy, but still it is very important, the medical management of diabetic retinopathy, and few new laser techniques which have come up, although I have not used most of them, but I'll just discuss their role. So I think laser still plays an important role in the treatment of diabetic retinopathy. This is the question, and I'll just try to answer it despite the popularity of the anti-VEGF agents. So before anti-VEGF, I think laser photocoagulation was the first line both for PDR as well for DME, but with anti-VEGF agents, we have got improved superiority, increased vision gain, and hence the role of laser is coming down and down, especially in DME. So this was the classical definition of high-risk PDR. Just for information, I'll not go into the details. So in the ETDRS, in the DRS study, they showed that PRP treatment will reduce the chances of severe visual loss by 50% or greater. So this is a classical PDR with NVD or NV, which can lead to further complications of vitreous hemorrhage, TRD combined NVI and leading to NVG. So the main treatment for PRP is a pan-retinal photocoagulation, which should be done with a wide field lens. You should completely cover the retina 360 degrees as anterior as possible, because most of the diabetic patients will have their ischemia anteriorly, although a posterior variant has also now been discussed a lot, but still I think a good pan-retinal photocoagulation up to the aura should be done in a case of PDR, especially in our country where the follow-up is not very good. Even if there is an early PDR, it's better to do a pan-retinal photocoagulation. So this is the standard procedure. I'll not go into details. I think everybody who is practicing retina knows how to do a PRP laser. So what were the disadvantages? There are several disadvantages which were there with a PRP laser, a conventional one. It causes a lot of discomfort. We have to do it in multiple settings. It can lead to scarring, and sometimes it can even lead to collateral damage to the other retina, decreased color vision, night vision, and even a contraction of the visual fields. And sometimes it can lead to choroidal effusions or raised IOP with risk of choroidal detachment. So these are the newer things which have come up. One is a targeted retinal photocoagulation. You should have ultra wide field angiography for that. What is targeted retinal photocoagulation? That you can just do a good ultra wide field angiography, locate the areas of ischemia and ablate only those areas of ischemia which are the source of the VEGF. So we eliminate that. So few studies have been done. I think it can be done only in the early stages, but again the patient has to have a very good follow-up if you're doing a targeted retinal photocoagulation. I've done in few patients, but the most important thing is a good follow-up, because if there is further ischemia, it can lead to further damage of the eye. The other laser are the pattern scan laser or the Pascal. What they have got a different set of patterns, and they really reduce the time. The patient comfort is also improved with it. So they are in the form of a square or an arc or a grid, and it really reduces the number of settings and the patient comfort. But there is also a disadvantage which is there, that it is less effective as compared to a standard pan-retinal photocoagulation. So There are studies, and I've even seen that sometimes the NV is not regressing very effectively, and it is better to do a complete PRP conventionally. So as I said, it reduces the time, it increases the patient comfort, and as it has got shorter pulsar durations, it leads to less tissue damage of the inner retina. So the drawback I've just highlighted, that there are cases which can have a recurrence of the NV or non-resolution of NV, and it is less effective as compared to conventional PRP laser. The other is a Navilas. I've not used it, but that is an image-guided laser system. So it specifically targeted retinal photocoagulation and predetermined and a highly precise manner is done. It uses infrared images, color photographs simultaneously, and you can go ahead with the laser. Again, it is very comfortable for the patient, lesser settings, but it is less effective as compared to a conventional panretinal photocoagulation. It can be even used in the management of DME. I'm just speaking about PDR at present, and it is a very highly efficient manner. It has been stored in studies up to 12 months, the macula remains dry. So now anti-VEGF role in PDR. I'll first discuss PDR. So according to the DRCR.net protocol S, so they were giving anti-VEGF injections every month. They gave it for 2 years, and they said that there is no need to laser, but this is not a viable option because most of the anti-VEGFs, their effect is up to 6 weeks or maybe 8 weeks maximum, and there is a very high chance of recurrence of these neovascular vessels, which can lead to severe complications like NVG. And somehow I think all of us are noticing that the incidence of NVG is increasing, not only because of PDR, probably even in CRVO cases, we give anti-VEGF agents and we don't call the patient, and the 100-day glaucoma has classically become like 1000-day glaucoma. So the patient, because we are not eliminating the ischemia by giving anti-VEGF agents. So in our country, it is not viable financially and for medically also. So for me, for PDR, PRP is still the gold standard. Coming to the second aspect is diabetic macular edema. It is the most common cause of legal blindness in India. This is again the classical definition which we had when I was a postgraduate. I think you should know it, but now we are mainly focusing on center involving DME and non-center involving DME based on the OCT pictures. So in the ETDRS, when they did a grid laser or a focal laser, they said that reduces the risk of moderate visual loss. However, visual gains are very limited. So it's very good to have these new anti-VEGF agents also. So because of this laser, there was a high chances of scar, even developments of choroidal neovascular membranes, and collateral damage was there because the laser scar tissue tends to increase over time. So as I said, these newer agents, they have really increased the visual results. I not go into the details, they all have been discussed. So the main treatment for DME is now, which I follow, is protocol T. I think both aflibercept, ranibizumab are very effective. We even have got faricimab, that is also very effective. But if the patient can't afford, you can go with the basic ranibizumab, and over a period of 2 years, that has shown almost equivalent results to aflibercept. But the catch is here that more than 50% of these patients after 2 years will have a recurrence and will need some adjuvant therapy like laser or a steroid. So laser still has a very important role even in the DME. So these are the, as I said, one is focal laser and the diffuse laser. These are the newer modalities which give a sub-threshold laser and they prevent the damage of the collateral damage. And Navilas, as I said, in PRP, it can also be used in DME. So selective retinal therapy is also, it gives very short pulses duration. I have not used it. So I'm just saying because newer techniques, and it prevents the treatment of the selective treatment of the RP, preventing the inner retina. Hence, it is much more safer as compared to doing a conventional laser. Same is the sub-threshold diode micropulse. I think Dr. Ajay really has used it a lot, but I have not used it. So the main role is that it prevents the damage of the retina. Even lesser collateral damage is also there. So it uses a near infrared diode lasers, and there is a burst of these laser which comes in sub-millisecond pulses, and it's quite safe to the fovea. So similar to SRT, SDM also provides selective therapeutic targeting of the RP, and there is no visible intraretinal damage or scarring either during or after treatment. So this is to summarize all the lasers which I just discussed, in which you can, pattern laser and Navilas can be used both for PDR and DME. However, selective retinal laser and micropulse can be used only for DME. The main important role is that they prevent the damage, the collateral damage to the tissue. Now coming to what is the role of the DME in the anti-VEGF agent, laser has become the second line treatment for center involving DME, but it still holds a very important place. And once you do a laser, especially you do angiography, you can see those extra foveal leakage points, and you could do a focal laser that only reduces the edema but also reduces the number of injections which are required. So it's very important to have a very good diabetic control also. Once you're doing a laser, it takes up to 2 to 3 months to the effect to come. So don't be in a hurry if you've done a laser that you want to see immediate effect. So when should we do a laser in a DME? Once for what laser can be considered as a first line when there is a non-center involving DME, or if a patient has got a recent stroke within 2 months, or a heart, or a MI, and the patient is also contraindicated for the use of steroids, probably because of glaucoma or some deep cups. So that is a case in which you can do a FA and we can do laser as a first line therapy. And the good thing of laser is you don't have to call the patient again and again. So, and laser therapy, as I said, can always be considered as a second line or a adjuvant therapy to anti-VEGF or steroid agents in all cases. So as a rescue laser, as in the protocol T, as I said, rescue laser was done in approximately 40 to 50% of the patients after a period of 2 to 5 years. Most of them required lasers. So this is the most important thing for while you're managing a proliferative diabetic retinopathy or a DME, that is the intensive control of blood sugar. These are the studies which have been done. I'll not go into the details. So a good control of diabetes, a good control of the systemic condition and the hypertension is very important for management of both DME as well as proliferative diabetic retinopathy. So my take home message is for PDR, laser PRP is still the gold standard. We can't replace it with anything else. Newer laser patterns, they give more patient comfort, they are much more safer, lesser time, but however in some cases they are not as effective as a conventional PRP, and they can lead to a resurgence of the neovascularization. Anti-VEGF agents have really become the first line of treatment for DME, but laser still has a definitive adjuvant role as a focal laser in most of the cases. And the other novel techniques of SRT and SDM, they are a new laser modality that prevents collateral tissue damage for the treatment of the macula. So thank you all.
Thank you, Bhuvan. You did a wonderful job with the lasers. Thanks. We'll have the questions at the end of the session.
Sure, sir.
Yeah.
Thank you.
I welcome Dr. Lalit. Despite his busy schedule in this conference with so many commitments, thank you for being here on time actually for your talk. So he'll be talking on vitreoretinal surgery in PDR, timing, stepwise technique, and tips for safe surgery.
Thank you, Ajay, for this very, very important course. Wish that this course had been placed at a more appropriate time. But in any case, Ajay, has been doing this course for now a couple of years. More important is Ajay is also the chairperson of AIOS Committee on Diabetic Retinopathy Task Force. And I did made one slide, which I am not here, but he has done a very useful work for AIOS, which involves how to do a mass, evaluation of visually threatening DR. And a lot of homework has been done, and I hope with continued efforts, we will take it forward. So thanks this entire committee for designing this wonderful program at this very nice venue. We are very thankful for that. You see 101 million diabetic and equal number or more pre-diabetics. Doctors not spared. That's the bitter pill. All of us, I did one survey amongst the registered delegates of AIOS. At that time, 29% of doctors were found to be obese and 18% diabetics without their knowledge. In AIOS registered delegate survey in the conference. That was done by Dr. Babu Rajendran at that time. So if I have to list 3 things in diabetic retinopathy, one is anti-VEGFs and lasers, which Bhuvan has just said, and third is advancing in microsurgery. So we have to, mix and match apart from metabolic control, kidney control, hemoglobin control, blood pressure control, lipid control. These 5 things which I normally put one stamp on the OPD card of everybody. But ये 5 चीजें आपने करनी है, बाकी डॉक्टर के ऊपर छोड़ो आप. तो ये 5 things we have to, a lot of work has been done by PGI and Mangat Dogra and team about this. So first and foremost, especially for younger generation, do not rush inside. Believe me, diabetic retinopathy is not such a straightforward thing that you tend to peel all the membranes. So safety, a good surgeon is one who should know when to stop. You see, you can't show surgical heroism by taking care of all the membranes. Remember, patient's vision is more important than anything else. So all these patients, who have only vitreous hemorrhage, who have not been lasered, we should resist giving anti-VEGF. Anti-VEGF is a boon, but does not mean that anything in diabetes, because West is pushing even to retard diabetic process also. It's not such a straightforward thing, especially in unlasered retina. Things like this which are stable and especially good vision, especially one-eyed patient, don't touch, and this looks like a burnt out process. This patient where you have to touch, and what has been done is only injection. So this is not forgivable to any more or less comprehensive ophthalmologist. I should issue a warning: do not keep injecting, because they keep injecting just to make a faster buck, but that is not acceptable at all. So vitreous surgery indications are evolving. When we were young faculty or residents, the only indication was non-resolving vitreous hemorrhage. And that time, our bosses used to tell us, wait for 3 months, wait for 5 months, 6 months. But threshold, because of confidence of MIVS, has decreased quite a bit. People now, if it is one-eyed or macula is threatened, you go inside even in 2 weeks also. But now the commonest indication which has become is a combined detachment or a macular TRD. Vitreous hemorrhage, thankfully, everybody is managing pretty well. So one part is only V component, that is vitreous. One is where retina itself you have to tackle. Only V component is not so difficult, but once you have to tackle membranes and TRDs, that is what is more relevant. I'll just show 3-4 videos only. This is actually one lady from Faridabad who had bilateral vitreous hemorrhage, and once she developed, then only her husband brought by a blind both eyes lady, young lady, IDDM. So only thing what I found after doing a core vitrectomy was this big front. And remember, don't cut very close to a disc. Leave it; it will shrink later on once you have isolated this from the vitreous cavity. And then these machines have become so good that you can do this base dissection reasonably fast. And then most important thing for this patient of PDR, which has bled in both the eyes, is this laser photocoagulation. And lasers you should take time. Surgery in this patient took 10 minutes, but laser took 25 minutes. Because I'm very fond of doing laser in a row with no skip areas like this. So dhire along the vessel arcades. First draw a Lakshman Rekha outside this macular arcade so that you don't go closer to this. And then do this laser photocoagulation. Here disc is good, macula is good, patient recovered 6 both the eyes, 6 both the eyes. And one of the most thankful patient because she came with hand motions only. So this is the end result, only air injection, no gas is also required. This is the post-op result, the other eye. So now I show 3-4 videos of PDR complicated with the increasing severity of complexity of surgery. This is more severe than what I had shown before. Again, principle remains the same. The toughest task in diabetic vitrectomy is to find the hyaloid plane. That's the most toughest task. And here we do a core vitrectomy. And then sometimes you will be able to make a hole in the hyaloid. So you try to identify the, here we have made a hole in the hyaloid, and retrohyaloid there is some lot of loose blood there, which gets sucked away with the help of suction only of the cutter, or you can have this backflash needle. But do not allow this blood to collect. If this blood collects, then you have to do slightly more time-consuming jobs. It will come out, but it will require some forceps, sometime diamond duster to find this edge. So don't allow this blood to collect. And after that, after you have done this removal of blood, you may have the thin membranes, and if it is easily peelable, you can remove like this. If not, then you have to resort to cutter or scissors. So then you do airflow exchange. This is, I think, must have been covered because DME, tractional DME is also becoming part of vitreous surgery. This patient had, I don't know, 10, 11 injections, but the culprit was traction. So you do a trichroid-assisted vitrectomy. A lot of these patients, we combine cataract surgery along with it, like is being done here. Remember, any degree of cataract may affect the resolution of doing a membrane surgery. So cataract is taken out, lens is implanted. Then we put this trypan blue dye to identify or make the membrane surgery more precise. So here we identify the edge with 25 gauge MVR blade, and then once edge is there, then this membrane generally comes out. And ILM also got peeled here. So this is slightly more complex, where we had to take a decision. This is because macula was very good, but it's a very tough, taut, solid-looking this thing. Graded way you have to see to it that with your eye on the retinal surface and on the disc, that you do not cause much iatrogenesis, because diabetic patients, a lot of iatrogenesis can be caused. Those two B's, don't forget, breaks and bleeding. They are two things which keep troubling you. So then we trimmed this and diathermized. We did not take up to the final, ora serrata, but we isolated that front nicely. Sometimes you may be doing this complex, removal of hyaloid membranes, and then sometimes you will be left with, a front which is where positioning is slightly difficult, like this, huge whitish-looking fibrotic membrane on the surface. We could not. अभी ये क्या हो गया? 4 था, 1 हो गया? अच्छा, ठीक है. So then you do positional kind of. You can, shift the position of cannulas. Okay, I'll just rush through. This patient, young lady, both eye, where we had to do a bimanual procedure, where you hold it with forceps, and you see bimanual procedure still has a role to play even in this era of 25, 27 gauge vitrectomy, because bimanual, I feel, makes the job very precise, less traumatic, less iatrogenic issues. So bimanual surgery, as I said, is definitely helpful in diabetics. This is the result of this young lady, bilateral, left eye, right eye. So we'll just skip through this pre-post videos, photographs. Ultimately, you see, also pay attention to the IOP, because a lot of people, raise the bottle or increase the IOP to 50, 60, but forget, this is what it should look like at the end of the procedure, that excellent laser should be done, because this is what is going to save the eye in the long run. This is the way I think laser everybody should do. This we'll skip. Okay, so pre-operatively, anti-VEGFs have made our life easier, because the bleeding gets minimized, surgical time also gets minimized. But assessment of the entire, system has to be done, including kidney status, and get a PAC done beforehand also. I try to stop blood thinners, definitely, in case I have to do a lot of membrane surgery. Try to stop blood thinners. It will definitely help, especially if the patient is on 2 blood thinners. So just to summarize, not an easy job. Multiple tenacious and vascular. Tenacious means that they can cause breaks if you pull. Vascular means they can bleed. So I remember these 2 B's, breaks and bleeding. So work slowly, take time. Normally I would keep diabetic patient at the last of surgery, because otherwise rest of the procedures may get affected. Patience is the key, and the end, laser, laser and laser. Outcomes have definitely improved from the days we, started doing surgery. Thank you very much for your kind attention.
Thank you, Dr. Lalit, for this crisp and clear and practical tips. So join us for the panel. I'll request, we'll have the discussion in the end. I'll now request Dr. Ritu to speak on cataract surgery in DR, timing, technique and choice of IOL. Bhuvan, can you please comment? Dr. Manisha? Sir.
Good morning. At the outset, I'd like to thank Dr. Ajay and AIOS for this opportunity. And it's really good to see so many people attending this early morning session. So I'll be talking about cataract surgery in diabetic retinopathy. How do we optimize the outcomes? As has already been said, that diabetes is becoming so very common in India. And we also know that cataract is so much more frequent in diabetics as compared to normal patients. And cataract not only develops more rapidly in diabetics, but it also occurs at a much younger age. And almost 25% of all our cataract surgery patients are diabetics. As has already been said, we need to optimize the diabetic retinopathy, of course. But to optimize the visual outcome, the cataract surgery has to be given special attention in diabetic patients. So what can be the indications for cataract surgery? Either you have an advanced cataract or there's poor visualization, and we know how important it is to monitor the retina. It could be combined with VR surgery, or it could also be an association with glaucoma. The main concerns that we do have in cataract surgery is the post-op CME, worsening of the diabetic macular edema, progression to PDR. As we know, the patients are more susceptible to increased inflammation, risk of infection, and the surgery itself is definitely more challenging, especially where patients has received multiple intravitreal injections or have had a VR surgery earlier. So managing the comorbidities preoperatively, intra and post-op is extremely important. In the preoperative management, we need to look at the systemic condition of the patient, whether the patient has associated nephropathy, any cardiopathy, neuropathy, vasculopathy, and of course the ocular, anterior posterior segment needs special attention. A good metabolic control cannot be emphasized enough, and the blood sugar levels, as has been said by AIOS in their handout also, that it should be less than 180 mg%, and we need to look into all the parameters of the patient prior to taking them up for surgery. Here itself, I can show you how a patient who had, center involving diabetic macular edema, just with a good systemic control, the patient was, the retina was well stabilized, and then the cataract surgery was planned at a later date. So it's also important not to, reduce the blood sugar levels very rapidly, as we know that can be, a bit deteriorating to the patient as far as worsening the maculopathy, causing a progression to PDR. So we need to counsel the patients that the blood sugar needs to be controlled, but in a slow manner. So preoperatively, there are very many challenges because of inflammation, ocular surface disease, neovascularization, glaucoma, poor pupil dilation, endothelial dysfunction, zonular instability, and also the cataract may be more difficult. So managing the inflammation preoperatively is very important. As we know, diabetics have a greater level of inflammatory mediators, and we need to start the NSAIDs preoperatively and also continue them much more than we would do in our normal cataract patients. So managing the ocular surface is also very important, as these patients are more prone to hypoesthesia, meibomitis, blepharitis. They could have poor wound healing, and also the unstable tear film, because these patients do have dry eye. That can lead to variable keratometric readings and could affect your biometry. Also look for NVI, and that needs to be managed preoperatively. Look for glaucoma, and your management of cataract depends upon the kind of treatment the patient is on, how well the glaucoma is controlled, the compliance, how much is the advanced glaucoma. And nowadays, of course, we are moving towards MIGS, and that can be well combined with the cataract surgery. Assessing the posterior segment is important not only for the management but medico-legally. So we must document it very carefully, and it also helps to prognosticate and counsel the patient as far as the visual improvement goes. Because for them, a motiabind operation is very simple, and they know that most of their peers, their family recover very good vision after cataract surgery. But the patients who are diabetic, we need to spend a little bit more chair time and counsel them not only that the surgery itself is going to be challenging, but they also need to continue a very close follow-up with their retina specialist. So sometimes the posterior segment treatment should precede the anterior segment treatment depending upon the visibility. So depending upon the clarity of the lens, we will decide what is the kind of intervention we need, what is the kind of diabetic retinopathy the patient has, and that is going to affect our decision for cataract surgery, whether we want to do an early cataract surgery if the patient is well controlled and has very mild to moderate NPDR, or whether we want to tackle the maculopathy and the PDR first in sequentially, depending on the situation. We also know that even if, despite a very good surgery, there can be a significant increase in the macular thickness despite uncomplicated cataract. And that again we need to look at, because we know that the blood aqueous barrier gets affected in diabetic patients. So intraoperatively, a few comorbidities that maybe need to be tackled with good viscoelastics, having pupillary expanders at your OT facility, having the CTRs available, capsular hooks, and also a backup IOL, especially where you may think that the patient has undergone several injections, the patient has had a vitrectomy, the patient could be having a pre-existing posterior capsular defect. So what kind of lens we would select? First of all, a very careful biometry needs to be done, especially patients who have undergone vitrectomy. And we always prefer a hydrophobic acrylic foldable lens. Heparin-coated lenses are available also, though not as much as they used to be earlier. And the big, dilemma is whether we can go for multifocal lenses. I would advise to stay away from them in patients of diabetic retinopathy. But yes, if you have a patient who's, say, in his 70s, he's well controlled, and now you know that, yes, the patient is unlikely to develop diabetic retinopathy. In such cases, you can go in for a multifocal lens, but counsel the patient about contrast sensitivity issues. Avoid using AC IOLs or iris fixated IOLs where possible. And EDOF lenses, which are the new game changer in cataract surgery, they can be used in well-controlled diabetic patients. So does the diabetic retinopathy increase the incidence of complications? Yes, it does, definitely. And so we cannot take cataract surgery for granted in diabetic patients. We should always try to do it with greater caution, and it should be undertaken by an experienced surgeon. So few interoperative pearls, you may want to give a block. The rexes should be of very optimum size. That's very important. Protect the endothelium. Avoid hydrodissection in patients which are post-vitrectomy. And the zonules may be weak, so you may need to go in for a CTR. A very meticulous cortical cleanup is important. And the IOL should always preferably be put in the bag. Removing all the visco is also important to avoid any IOP spikes. And in case where you may be thinking of laser or vitrectomy after the cataract surgery, a suture is a must. So the post-op management is important. It should be an aggressive topical steroids. NSAIDs should be continued for much longer. Lubricants are very important because these patients do have disturbed ocular surface. The glaucoma part needs to be followed up regularly. Avoid an early YAC capsulotomy, and do counsel the patient to follow up with their retina consultant. They should not be lost to follow up. That should be very much underlined to the patient. So my take-home message is that the outcome is very good now, provided that the retina part is well looked after. A pre-op fundus examination is a must, and we need to manage the comorbidities before taking up the patient for cataract surgery. So systemically, the patient should be stabilized. The retina should be optimally stabilized before taking up the patient. And managing the macular edema, because we need to differentiate between cystoid macular edema and a diabetic macular edema. That needs to be seen, and we also need to tell the patient that they have to come for frequent post-op follow-ups so that the retina can continue to be stabilized. Thank you so much.
Thank you, Dr. Ritu. I request Dr. Rajiv now to talk on the much-awaited talk on AI in diabetic retinopathy, current status and future prospects.
Thanks, Dr. Ajay, and it's a real pleasure being in this instruction course for last couple of years. And I think many of the talks have not changed, but this talk I had to totally change because many things happened in last year. So I'll be talking on some new frontiers in AI for diabetic retinopathy, and already we know that diabetic retinopathy affects millions. The prevalence of diabetes in India is less than that of US. The problem is our absolute numbers. Our absolute numbers are so high, you cannot have, so traditional screening and treatment is challenging, especially if the prevalence is pretty high, and AI is probably poised to bridge this challenge between screening and treatment. There are a couple of challenges. We have high prevalence, more absolute numbers. Though we have very nice guidelines from AIOS, VRSI, there is no structured pathway for diabetic retinopathy screening. Again, it's not feasible to have annual eye exam for everybody. We don't have so many cameras. We don't have so many people to take the photographs. And there are also a couple of AI algorithms which are inbuilt into the camera. However, uh, these AI algorithms also have got their own limitations. So there are a couple of emerging innovations, some potential breakthroughs, and some future perspectives as far as AI is concerned. The emerging innovations are there which are already available today for use of many of us in the market, and I'll be talking about them. So in India, we have a couple of these non-Mydriatic cameras which come with the AI platform which is already there, and that makes a remote diabetic retinopathy screening feasible. Many of them also have got image gradability checks, meaning that if it's a poor quality image, the AI gives a prompt that you can retake the image. So the commercially available ones like Zeiss comes with Selena, which is developed by Seri, Singapore. We have the Forest camera, which they have their own algorithm. They also use the Google ARDA AI algorithm. Remedio, very well tested in Indian settings, published. They come with their own AI algorithm. We also tried developing with Professor Tin Wong an algorithm which could predict diabetic retinopathy progression. Again, this was a multicentric study, and in Indian population, in our population-based data, we could show that we could increase the screening interval by about 32 months, and delayed detection rate was only 0.37%, meaning now you take a baseline photograph, you can say what will happen at 4 years. How these all would be translated is something which is a real challenge. The problem is that, as I told you, that we don't have so many cameras. So one of the way we thought looking at is, can we triage the patients by first looking at risk factors. So we used all the population-based studies which are published from India and developed an algorithm, machine learning algorithm, where you feed in these factors. This is a small video. So you feed in the age, gender, systolic, diastolic BP, BMI, duration of diabetes, and fasting blood sugar. That gives the output, what is the chance of having DR, and probably those who have high chance getting a retinal photograph for them may be one of the solution. Meaning that especially in our country, before screening, we need to have a pre-screening. Pre-screening could be a risk-based, risk factor-based algorithm, or probably a blood-based biomarker, any one of them, to triage patients for retinal photography. In DME and AMD both, there are now a couple of these algorithms which can quantify the fluid levels, and this is one of the work we did with Zeiss, and now the newer OCT machines are coming with these which can probably quantify all the fluid levels, which will definitely help us in treating these patients. There are a couple of potential breakthroughs which are still not there, but definitely they are something which we'll see in next few years. Definitely LLMs, the large language models, have paved its way in diabetes management. And again, this was one of the work where even we were part of it, so we could validate it in our country, where we tried using deep learning model for retinopathy and large language model to give advice. The beauty was that it matched and exceeded the primary care physician's recommendation. Even in terms of empathy, it could work pretty well. There are now many diffusion models which are coming up, which can actually give a more fair diversity. Diffusion models have been used in dermatology a lot, where these are generative AI, where it generates the images. And now using these, you can target synthetic images. You want like less age or more severe diseases, you can generate based on that, so that your data is more complete and you can get a better AI algorithm. More focus is going towards foundation models. These are the models which are not small, millions and millions of things, and there are many of the ophthalmology specific foundation model. The first one was by Dr. Pierce Keen from Moorfields. Second was from China, and now there is an effort towards a global initiative to generate ophthalmology specific foundation model. Coming to some future perspectives, people are now looking at predictive health analytics. This was one of the review article where we showed what are the various systemic diseases from retinal images people are looking at. This was a work we did with Cambridge consultants where we tried looking at can we predict neuropathy from retinal images, and we could demonstrate for the first time that AI algorithms, though in neuropathy you don't see anything on the retina, but we had shown there are functional changes in terms of sensitivity changes which happen in the retina, but deep learning algorithm can to some extent detect neuropathy from retinal images. Very recently, we had published the work on anemia because we know that diabetics have more anemia, especially those who have renal diseases. And we could find out using AI algorithms detecting anemia, not only presence or absence, but also suggesting the mean hemoglobin level from retinal images. We found that the heat maps looks into peripapillary area, and we tried looking at and found that it's the vessel tortuosity and density which plays an important role, maybe a future biomarker as far as anemia is concerned. One of the things we have heard is about inflammatory mediators, and we know that you have more of these inflammatory markers. Probably the response to anti-VEGF is a bit less. We developed an algorithm by which you can put the images and get all the inflammatory marker score, and it gives an inflammatory score which gives us an idea whether it would be a responder or a poor responder of anti-VEGF. So you feed in the OCT, it gives a score for all of the inflammatory markers, and we get to know whether this would be a good responder or a poor responder. More recently, we have, just last slide. More recently, we have worked on another concept of retinal age gap, and we showed it as an independent risk factor for proliferative diabetic retinopathy. It's an AI-driven biomarker. By using retinal image, you can predict the age of a person, and if there is a retinal age gap, meaning the retinal age and biological age is different, it's been shown as a marker for mortality. They are more, so we showed that it's not only mortality. Yes, mortality was one of the things. We had 4-year follow-up of these subjects, and they were more, if the retinal age gap was more, they had more chance, twice the risk of mortality over 4 years. However, we also showed that this age gap is an independent risk factor for progression to proliferative diabetic retinopathy. So to conclude, the AI is addressing a lot of key challenges in diabetic retinopathy screening and treatment. There are a lot of innovations and predictive tools which are paving way, and definitely it will be a more personalized care, and the future promises integrating it into multi-disease screening. Thank you very much. I'd like to invite all of you for the APOTS Retina meeting, which will be there in July.
It's loaded, no? Yes. There. So audiovisual, can we have Dr. Manisha's presentation on, please? This side? Manisha here. And we have a keynote address in the end. I'll request Dr. Sampath to put his laptop there so that after this we can. Thank you, Dr. Lal.
Good morning, everyone, and thank you, Dr. Ajay, for making me a part of this wonderful session on diabetic retinopathy. I think Rajiv has beautifully covered what's going on new in artificial intelligence and DR. However, we need to understand that there is a lot happening even in diagnosing diabetic retinopathy. So wide field and ultra wide field fundus photographs are very much in use now. And the difference that these wide field images have made, that they've led to classification of greater degrees of DR severity in about 20% of the eyes. So the eyes which were considered to be of lower severity are now thought to be of a much higher severity. The peripheral DR lesions are independently correlated with an increased risk of PDR, and probably these lesions were not caught earlier. As far as the screening of DR outside ophthalmic clinics is concerned, it's primarily focused to telemedicine and also to the use of non-mydriatic fundus cameras with artificial intelligence. The advantages being easier access and better compliance, as these screenings can be done at primary healthcare provider clinics and not necessarily ophthalmic clinics. So here you see this is a small model of how we are going to be doing a DR screening using telemedicine, and the turnaround time could be as short as 1 hour. But if we are going to be using an AI tool, a non-mydriatic fundus camera with an AI, the turnaround time can be as small as 1 minute. So this has made a huge difference today in DR screening. And more recently, artificial intelligence and deep learning may now be able to prospectively predict the incidence and progression of DR, as Rajiv rightly mentioned. So these are the various aspects of artificial intelligence being applied for an earlier and for a better screening of a diabetic retinopathy. Coming to certain imaging techniques like fundus fluorescein angiography, it has played a very important role earlier also, where we want to grade the severity of DR. It's an invasive procedure. However, it's still considered the gold standard for management of DR, and these are the various indications why we perform a fundus fluorescein angiography in a patient of diabetic retinopathy. However, now with a wide field angiogram, it reveals much more than a normal angiogram, and as you can see over here, the ETDRS fields that we used to be earlier capturing is just limited to a very small portion of the fundus, and now we are able to capture far more in the periphery, leading to much more diagnosis of severity of diabetic retinopathy. Here again, you see in a wide field FFA a patient who's already undergone a laser photocoagulation, but because of the wide field wide field FFA, you were able to see that there are extensive capillary non-perfusion areas in the periphery and requiring a much more tightly packed laser photocoagulation. Coming to OCT, now we are talking of various biomarkers which are helping us in better management planning of diabetic macular edema, and these could be an epiretinal membrane, a neurosensory detachment, a drill as you see over here, a DROL, a hyperreflective foci, and based on what biomarker you are identifying on the OCT, your management line can also differ. So if you are having a patient with an epiretinal membrane, of course surgical management is going to be your prime management. If you have a patient with NSD, probably you are going to be scoring steroids over anti-VEGFs. If you are seeing a drill, probably the patient is going to be having a poorer visual prognosis. Coming to OCTA, it's a non-invasive tool again for both qualitative and quantitative assessment of macula, including macular ischemia. It's non-invasive, so it can be repeated as many number of times as you want. And various features of diabetic retinopathy can be very well identified and picked up on an OCTA. The various OCTA metrics that we use in a DR patient is vessel density, the area of the FAS, the area of the non-perfusions, and it also helps us to monitor the progression of the DR. So here you see how beautifully this has picked up the neovascularization, which is proliferating into the vitreous phase. And after you've done the laser photocoagulation, there is a good regression of the entire NVE, and it's beautifully picked up on an OCTA. Now, what is new? We have been always talking of diagnosing DR when we are clinically seeing the various manifestations of DR. But with newer imaging modalities, we can actually recognize DR at a subclinical stage. And OCTA plays an important role in doing so. It can offer an opportunity to detect it at a subclinical stage in a non-invasive way. And this can totally impact our follow-up and the management. So the changes that can be helping us in detecting DR at a subclinical stage could be a decrease in the deep plexus vessel density, the enlargement of the FAS, the decrease in the parafoveal vessel density, both in the superficial and the deep vascular layers, and the impairment of the choriocapillaris flow. And again over here, I just want to show you that the CNP areas are very beautifully picked up. And this is a patient who's not having any clinical evidence of DR, but because you're having the CNP areas, you know that it has started setting in. The future in diagnosis of DR is the integration of these ultra-wide field color fundus photographs, the OCTA, the omic and the other biomarker research, the artificial intelligence, and of course the statistical modeling. And all these put together are going to help us in facilitating a newer DR classification even before we have the visible DR lesions. And these DR lesions are very typically seen on the two-field retinal screenings and can help in personalized care for DR management in future. We have a lot happening in the management of DR as well, like the Lovago Therapeutics is developing a human antibody therapy that not only treats the symptoms of the condition but also has the potential to renew healthy vascular growth, reversing retinal degeneration, and providing hope for the many who do not respond to current medications. We are also having certain eye drops being developed for management of DR and DME, the advent of the genomic-wide analysis, metabolomics, and proteomic profiling for DR, marking a new frontier for future management. And of course, stem cell therapies and genetic interventions are also being tried. So there's a lot happening both in the diagnosis and for the management of DR, and the future holds strong. And I'm sure that the kind of visual prognosis we have in the patients right now is going to totally change in future. So thank you so much.
Thanks a lot, Dr. Manisha. That was very, stimulating. Very stimulating. And I know that in India now we have enough centers doing cutting edge work. We have a keynote address by Dr. Sampath. He'll be talking on Vabysmo experience in diabetic macular edema solution in double whammy. He is a practicing surgeon at Kettering, UK. Product of HPC.
Thank you, Ajay, and thanks to the AIOS for this opportunity. And thank you all to make it to the earliest session of the last day, actually. So I'll just get started. I have no financial interest for this session. Now, I think, right at the outset, we have gone through quite a few presentations showing this sort of impact of diabetes and what it's doing to us. This is actually a world map, and what it doesn't show is certain countries in the Pacific Ocean. So these regions, including Samoa, Nauru, they have 1 in 3 of the population have diabetes. So that's the extent of the problem that we are facing. And this is again a slide which part of which was shown by Ajay, just to show what the burden is and what the projection is. A lot of work is being done and a lot more needs doing. No talk on diabetic macular edema is complete without showing you the cascade of events that actually take place. Right at the top we have the culprit hyperglycemia and the accomplices dyslipidemia and systemic hypertension, which kickstart molecular biological pathways leading to oxidative stress through reactive oxygen species, inflammation, and we have an upregulation of all these cytokines and chemokines. And we all know about VEGF, but there are a lot of others as well, including the angiopoietin-2 and etc. So the more we claw into these by down-regulating the upregulation or preventing the upregulation, then we have better outcomes in the patient, because not everything is sorted by anti-VEGF alone. Okay? And there are all these capillary changes that are taking place leading to diabetic macular edema. Now, we always base our management of patients based on the evidence. And thanks to all these workers coming up with great studies, I have highlighted 2 here. One is faricimab, because I'll be sharing with you the work that we have done at the University Hospitals, Northamptonshire. And I've also highlighted this because we should never underestimate the value of giving proper advice for the systemic control. Okay? And just as an example, Dr. Agarwal just showed, every 1% reduction in HbA1c will give you a 37% reduction in the diabetic retinopathy. So that's very, very important not to forget explaining about the systemic control. So the approval, of course, is based on landmark studies. I'm not going to go into details of these, but just to show that the 2-year gain from this will be roughly about 11 letters. So we started waving the magic wand in our department in June 2023. Surgeons jumped up with joy, and that's me jumping up with joy. But we were just barely recovering from the COVID at that time, so we had a lot of capacity issues. Okay? And thousands of notes were actually looked into to sort out priority, which ones come in first and not. We had virtual clinics with our wide-angle cameras, and we managed to reduce the waiting time considerably. We had one-stop injections, which also helped us. And we designed a treat and extend pathway of the faricimab, which we put up, sort of laminated sheets in each clinic room. So every clinician sort of sang from the same laminated hymn sheet. And that is the, the sheet. So basically all the new patients, had faricimab, and those who were having inadequate response to the other agents were also transferred onto this pathway. And as you see on the left-hand side, you see if you have adequate response to it, then we keep on extending the interval to reach the 16-week interval. If at any point in time we had, inadequate response or a fresh activity, then it goes back into either 4-weekly or 6-weekly, and then we follow the thing based on the response again. So the visual acuities were recorded in Snellen and converted to letter scores, both in the outpatients and the injection appointments. An OCT was performed at each clinic visit. Data was also collected on the HbA1c and the eGFR. So we had 276 eyes of 206 patients in the pathway, of which 141 eyes of 98 patients, they had completed the loading dose of 4 injections. And I have all the data on those who have finished the loading dose, so that's what I'll be presenting. So these are the distribution of the sort of gender, the age, etc., and the HbA1c, eGFR. We also just saw, how many of them were graded for the retinopathy ones. We found a majority of them with the R2 or the pre-proliferative state, which might make sense because these are probably, liberating more VEGF, and there's more VEGF drive in these patients. And the R3 ones have already been treated with PRP, so the VEGF drive probably reduces after that. So we looked at the 141 eyes, and as you can see, the histogram, all those which are beyond the 4 mark have completed the loading dose. And these are patients with individual number of injections. So we have 31 patients with 1 injection, 56 with 2, and 37 3, and then so on. And a lot of these, patients will be shifting to the right. In fact, this data was at the end of February. So by the time I get back, a lot of these would have already had their loading doses and then gone beyond on the right-hand side. So we looked at these patients as switched patients and naive patients. Okay, so we had about a quarter of these patients were naive, and that naive number will keep on increasing because all the new patients will be coming into this pathway directly. And amongst the switch patients, we had a majority of them who have had, Lucentis or ranibizumab, and the others as shown in this figure. We also looked at the interval conversion data because it's important to see when they finish their loading dose of 4 injections, how many of them are being able to extend it to 6 to 8 weekly. And we had nearly 90% of these patients going on to that interval. And we had about 5% who continued on the 4 weekly. So these are more sort of refractory cases. And once the loading dose is complete, they come into the outpatients. So there was a 7% of these patients, numbering up to 10, which was yet to have the appointment. So I would expect them to have the same distribution as the other 3. So the change in visual acuity we saw between the switched and naive, and you can see this is important here on the right-hand side. The mean change in the letters was just under 10 for the switched group and about 10.5 letters for the naive group. We looked at the central subfield thickness, and as you could imagine, the naive will have a much greater mean reduction. We saw about 215 microns of mean reduction compared to just under 115 microns in the switched group. We looked at the 70 letter threshold analysis because 70 letters is usually the driving vision. So that's the important sort of threshold. And we looked at all the patients who have completed the loading dose who had vision of less than or equal to 70 letters before, who gained sort of more than or equal to 70 letters after. And we noticed that the number is approximately 1/3 of the whole cohort of patients. But if you look at the the side here in orange, that is the mean reduction in the central subfield thickness is much higher. So basically, this drug has a very good drying capability. And just as a simple example of one of these naive cases, you see 730 microns reducing straight away to 298 with a single injection. So it's one of the more drying anti-VEGF agents that we have at the moment. We also wanted to look at those patients who actually lost vision. So we had 2 in the switched group and 3 in the naive. But we noticed that most of them actually had significant epiretinal membrane. That was the reason. And one of them in the naive group had quite uncontrolled sugar with about 118 millimoles per mole, which is about 270 milligrams per deciliter. We had no safety issues with this in the DMO group. We did have in the AMD group though, but luckily I'm not presenting that here. We had 1,112 injections of the 276 ICE with no problems. Really, in conclusion, so we are at the mercy of the capacity guillotine, and the real world is always very harsh compared to the trial data. We could have even better results if the compliance is met properly. But faricimab, Vabysmo, has been a significant step towards better patient care. It shows excellent drying capability, fantastic safety profile. Data is still evolving, and in the future, I'll be happy to present the updated data. And this is just a picture of our hard-working team, minus the even harder ones who were not here. So thank you very much.
Thanks, Sampath, and thank you for this wonderful keynote. I want to thank all the speakers for this wonderful session, and I'm sorry for the next session. We are a little bit impinging upon your time. We started a little late, so as a summary, I would like to say that the diabetic retinopathy will come a long way from DRS to what we are doing today. We are now looking at understanding the metabolism of what is happening in the retina. Newer molecules are being intervened upon. AI is coming into the picture, and with the ability of diagnosing it early and treating it more specifically, I think we'll be there in trying to prevent the blindness that diabetic retinopathy induces. The particular challenge for us in our country is the volumes and the timing by which the patients come to us so late. Hopefully, with AI coming in, we should be able to detect them earlier and treat them better. Thank you very much. Can we have a quick group photograph? Is the cameraman there? Manisha, come. Come, Sampath. Yes. You have any questions? Yeah, go ahead. Come there.
So good morning, everyone, and very thankful for this elaborate and informative IC. I have few doubts regarding. First of all, I'm a vitreretina trainee, so my questions might seem a little childish. My first doubt, sir, you recommend in cases of flat NVEs, we come across few patients who come first time getting a retina checkup, vision 6/6, coming with a flat NV very close to an arcade. What do you recommend? In one of your slides, you said you would recommend. So we have to go first anti-VEGF.
By that time, that neovascularization disappears.
Yes.
But if you don't do the laser, it will come back with a bang. So give the anti-VEGF. 1 week later, I will start the laser. And that area specifically, I will talk.
Sir, PDR definitely laser. You recommend injection first and then laser, right?
1 week before.
1 week. So another question regarding the pros and cons of ILM peeling in cases of diabetic vitrectomy. Is it routinely practiced or?
No, ILM peeling can be tricky because it can actually, you can sometimes get a macular hole with that also. So not to be taken lightly. ILM peeling in a diabetic macular edema is, the ILM is very parchment-like, and it's sticky. It's not easy to remove.
Yes.
So only if you believe that the patient's chronic macular edema is a consequence, yes, but not every diabetic vitrectomy I would do an ILM peeling.
Okay. Wherever we are finding it can be easily peelable, there you advise. Another question to ma'am, you advised YAG capsulotomy later in patients with the cataract.
Definitely,
So,
you
what-
don't want to open up the posterior capsule in patients of diabetic retinopathy. So you need to delay the yak capsulotomy as far as possible.
Ma'am, but why? Sorry, if
See.
for CME. Oh. Okay, thank you, sir. Thank you so
Thank
much.
you. And where are you from?
Sir, I am from Center for Sight, New Delhi.
Good,
but-
good, good, good.
Thank
Okay.
you, sir.
Small question to Dr. Sampath sir. Sir, in case of Vabysmo, we are using once monthly for 3.
So we have 4
So-
injections, 4
So
weekly.
this is your trial or
No, no, this
for
is
4
the,
injections,
this is the
or
loading
this
dose.
is the loading for
This
4.
is the loading dose, yeah.
4.
Yeah.
And sometimes I find that drying with brolucizumab is more than faricimab in the first injection, whereas after 2 or 3 injections, faricimab is comparable or more in drying. What is your take on that?
Amongst all of
Fast-
the agents so far, the drying is much
fast,
more with
First injection, brolu dried more.
Yeah, I wouldn't look at the first injection, to be honest with you, because our data was actually based on all the 4 injections.
After 4 loading
But the
injection.
example I showed was one of these with the first injection.
Yeah, thank you.